So let's start. So we are done with liver, bile duct and gallbladder and pancreas. So now we are starting with other part of the gastrointestinal system, that is esophagus. Okay. So before going in detail about the pathology of esophagus, we'll start discussing about the anatomy of esophagus. So anatomy, length of esophagus is about 25 centimeters. There are certain structures in our body whose length has to be remembered. One of them is esophagus. I think we'll do endoscopy, and for that, if we are putting a tube into the esophagus, we should be knowing the length of the esophagus, so that how much deep is esophagus, after which we'll get stomach, after that we'll get duodenum. So each of the length of GIT is important in case of endoscopy. Right? For that reason we need length of esophagus, and its extent is from C6 to T11. Basically, whatever the prominent part you will feel over your neck, back of the neck, that is usually C7. That is a spinous process of C7 vertebra, usually in the behind of your neck, whatever the prominent part will be there. So esophagus will be one level above, from there till first thoracic vertebra, T1. So C6 to T1 is the extension of esophagus. Okay, and usually it is a flat tube, it is not open always. Whenever the food goes, it will just bulge out and allow the passage of food. Okay, so just like I have mentioned, during endoscopy we need to know the exact anatomy of esophagus. So on endoscopy we'll see three narrowings in the esophagus, which is from the upper incisors, like they have mentioned the distance from the upper incisor and the narrowing. Okay, so if esophagus is a tube like this, and okay, imagine this is a person. Okay, this is esophagus from C6 to T1, and this is upper incisor. Okay, so whatever the distance they are saying, that is from the upper incisor to the narrowing. So there are three narrowings. When we do endoscopy, we will see three narrowings of the esophagus. First is at the cricopharynx, that is cricoid and pharynx. So just like we all know, in front of esophagus is the trachea, right? And this will go, and then it will divide into two bifurcations, and then it will connect into lungs in the thorax. Okay, so yeah, basically it will be from here, nose alva nasopharynx. So in the trachea one connection irutte. So from here trachea will go, and then at the level of T4 there will be bifurcation. So this is basically trachea. Okay, from the upper incisor at around 15 centimeters is the first narrowing of the esophagus. So narrowing antandre basically it's a constriction. Okay, ಇಲ್ಲಿ cricoid ಇದೆ ಅಂದರೆ ಇದ್ರ ಹತ್ರ esophagus will be constricted. Again it will go, and next one is at the arch of aorta, that is at the level of T4. I mean at the next level, that is like this, where arch of aorta will be coming like this. So whenever it is passing from above the esophagus, it will constrict the esophagus also. And then at the level of left bronchus, I have told extent of esophagus as T1, it's T11. Sorry, it's T11. That is, it will continue throughout the thorax. So till T11 esophagus will be continuing, and this is at the level of T4 trachea will divide into bronchus, like two different constrictions. Okay, so this is level of T4. Same at this level, from the heart there will be arch of aorta. So this is cricopharynx junction, there is the primary constriction, and then at the level of arch of aorta, that is about 25 centimeters from here, is the second constriction, and at the level of left bronchus is the third constriction. Both are same. okay, arch of aorta and left bronchus, because both are at the level of T4. After that, it will go, esophagus will go and enter into the, here is the diaphragm which is separating thoracic cavity from abdominal cavity, and through the diaphragm it will pass. So at the level of diaphragm also, it has a constriction, that is 40 centimeter. So basically 15 centimeters, 25 centimeter and 40 centimeter. At these three levels from the upper incisor, esophagus has narrowings. Okay, na? So this we need while doing endoscopy. These will be helpful. After passing first narrowing, we will be getting to know, okay, we have passed 15 centimeter. After second narrowing, we will know we have passed 25 centimeter. After third, we will know that we are entering into abdominal cavity. We have passed the thoracic cavity, or we have passed through the diaphragm, etc. So these serve as the levels. Okay, this is the most asked question usually in case of esophagus. Okay, so next, what is the lining epithelium of esophagus? It is a stratified squamous non-keratinized epithelium, just like the oral cavity. Okay, whereas it has muscles which is having a transition. So upper one third of the esophagus will be having stratified muscle or skeletal muscles. Okay, you can voluntarily control these muscles. Whereas lower one third is smooth muscle. In between there is a transition from skeletal to smooth muscle. Okay, so skeletal is in the upper one third, smooth is in the lower one third. In between there is a transition. So this you can voluntarily control, which is like swallowing. ಇದನ್ನೆಲ್ಲ ನಾವು ವಾಲಂಟರ್ಲಿ ಕಂಟ್ರೋಲ್ ಮಾಡ್ಬೋದಲ್ಲ. ಇಫ್ ಯು ವಾಂಟ್ ಟು ಸ್ವಾಲೋ ಯು ವಿಲ್ ಸ್ವಾಲೋ, ಅದರ್ವೈಸ್ ಯು ಕ್ಯಾನ್ ಸ್ಪಿಟ್. ಸೊ ದಟ್ ಈಸ್ ಅಂಡರ್ ವಾಲಂಟರಿ ಆಕ್ಷನ್, ಹೆನ್ಸ್ ಇಟ್ ಈಸ್ ಅ skeletal muscle. Whereas smooth muscle, once you have swallowed, you can't vomit it out unless you go for gag reflex. So smooth muscle is involuntary. Okay, and in between there is a transition from skeletal muscle to smooth muscle. This is the lining epithelium and muscles of esophagus. Then what is the characteristic features of esophagus when it comes to histology? Like we have discussed in gallbladder, there is no submucosa. In case of esophagus, there is no serosa. Serosa andre, it will involve peritoneum. Even though being a part of gut, esophagus is not having peritoneum. Hence, it lacks serosa and it will have adventitia. So the fourth layer, which is mucosa, submucosa, muscularis externa and serosa or adventitia ಅಂತ ಹೇಳ್ತೀವಲ್ಲ, serosa ಇರಲ್ಲ ಇಲ್ಲಿ, adventitia ಇರುತ್ತೆ in esophagus. Okay, so intestine, stomach ಇಲ್ಲೆಲ್ಲ villi ಕೂಡ ಇದೆ in order to facilitate the passage of food movement, but there is no villi in case of esophagus, and there will be no secretions. It is just a food pipe. It is just connecting the mouth and stomach ashte. There is no secretory functions, there is no other functions, other special functions. Okay, there is no Meissner's plexus also. And Meissner's plexus is usually for secretions only. So hence, since there are no secretions, there is no Meissner's plexus leaded. Then it has only single plexus, that is Auerbach's or myenteric plexus. Myenteric plexus ನಾನು ಹೇಳ್ದಂಗೆ, it is in between the muscle layers. If this myenteric plexus is activated, it will cause peristalsis, that is movement of food. So ಇಲ್ಲಿ ಬೇಕಾಗಿರೋದು ನಮ್ಗೆ ಅದೇ ಒಂದೇ ಫಂಕ್ಷನ್, food should move from mouth to stomach. And for that, peristalsis is needed, and for peristalsis, Auerbach plexus is needed. Hence, in the anatomy, we have Auerbach's plexus. There is no secretion of any digestive enzymes. There is no digestion happening in the esophagus. Hence, there is no secretions, and there are no Meissner's plexus. Clear, la? So these are the characteristic features of esophagus. What is a unique feature is there is presence of lymphatics in the lamina propria. Obviously, the food, whatever is there from the mouth, it is directly getting into esophagus. So, if there are any contaminants, they can lead to infections in the esophagus. In order to prevent us from infections from the outer environment, God has given lymphatics in the lamina propria. These act as defense mechanism. So whatever the lymphatics are there, obviously it will act as a defense mechanism, and hence it will prevent us from getting infections. So this is an extra feature which is there in the esophagus in order to prevent us from infections, okay, or foreign agents, whatever, as you say. Okay, so after this, what are the other features of esophagus? It is a narrowest tube of gut or GIT. Narrowest part of the esophagus, like, is cricopharynx. That is the first constriction. Its diameter is just about 1.5 or 15 mm ಅಷ್ಟೇ. Any foreign body that can cross the cricopharynx will pass the gut and will be excreted in stool. ಅದಕ್ಕೆ ಇವಾಗ, if a baby is brought to you or is brought to your clinic saying it has consumed coin, and you do endoscopy or you try to visualize it, and If you make sure that it has past cricopharynx, and if it is not sharp object or anything, you don't have to do anything. You can reassure the parents that it will come out through stools because it has past cricopharynx, which is the narrowest part of the gut. So you don't have to do anything, and you can just reassure the parents and just send them home. If it is a sharp object, then there can be a problem because it can lead to injury to the mucosa of the gut, and hence it need to be removed. Sharp foreign bodies and button batteries, these also. Button batteries are like whatever we used to see in uh, those toys and all, small batteries which will be of two different diameters. Okay, those batteries should be removed. Other than that, if it is blunt object like a coin or something, we can leave it, and we can assure the parents. Okay, so this was about anatomy, basic anatomy, like what are the three constructions of the esophagus, what is the length of the esophagus, and then lining epithelium and muscles of esophagus, what are the characteristic features and unique feature, and some other features of esophagus. So now we'll be starting with diseases of esophagus. First one being congenital diaphragmatic hernia. Okay, so as the name suggests, it is congenital. It is usually seen in uh, it is a genetic. Okay, congenital andre through from birth itself they will be having congenital diaphragm and hernia. So just the name suggests everything. It is seen in children. Okay, hernia is through diaphragm. So whatever the content is there in the abdomen will pass or will herniate into thoracic cavity through whatever the openings or the weak wall is there in the diaphragm. That itself is the pathology here. So protrusion of the viscus or part of viscus. Viscus is nothing but intestine or bowel or part of viscus through the wall of its containing cavity. So basically whatever the intestine or loops of intestine or viscus is there, it will pass and it will herniate into the thoracic cavity through the diaphragm. Okay, in that there are 2 or 3 types of hernia which we need to know. Okay, the first one being Bokdalek hernia. Bokdalek and Morgagni, these two are the ones we should remember anytime. Okay, so Bokdalek hernia, it is the most common type. It is also known as left-sided posterolateral. Left and posterolateral. So it is just saying the location of hernia. Like suppose if we are seeing from the top, and this is the diaphragm. Okay, here is a vertebra, and here is esophagus. So if this is diaphragm, it is okay. So ivaga we are seeing from the top. This is left side and this is right side anta ankoona. So left sided posterolateral. Here there will be a weak wall of diaphragm. So whatever the contents are there below, that will pass through this posterolateral defect in the diaphragm, and the contents will herniate. So this hernia which is occurring in the left posterolateral part is called as Bokdalek hernia. Okay, similarly if it happens in the anterior region, so ivaga ಇಲ್ಲಿ sternum irutte, between the sternum and the diaphragm there will be a weak point. If the herniation happens here in the anterior just below the sternum, then that is called as Morgagni hernia. ಗೊತ್ತಾಯ್ತಲ್ವಾ, ಸಿಂಪಲ್. ಸೊ ಇಲ್ಲಿ ಏನಾಗುತ್ತೆ, ವಿ ಶುಡ್ ನೋ what are the other facts related to Bokdalek and Morgagni hernia. So Bokdalek hernia, it is most common and it is known as left-sided posterolateral. Okay, that we got to know. Incidence is usually 1 in 2000 to 5000. Okay. Other than that, cause failure of fusion of pleuroperitoneal canal at left side. So what is the cause basically? I told you there is a defect in the left-sided posterolateral wall. So since it is a congenital hernia, there is embryological origin. During embryology, we need to know how diaphragm is formed. So diaphragm is arising from 3 different structures. One is septum transversum, other one is somites, and the other one is pleuroperitoneal canal. Basically, pleuro means lungs, peritoneum means abdominal cavity. Basically, thorax and abdominal cavity na separate ಮಾಡ್ತಿದೆ ಅಲ್ವಾ. So peritoneal, I mean thoracic cavity ಇಂದ pleural layer, abdominal cavity ಇಂದ peritoneal layer ಎರಡು ಬಂದು ಫ್ಯೂಸ್ ಆಗಿ diaphragm ಫಾರ್ಮ್ ಮಾಡ್ತಿರುತ್ತೆ. If there is failure of fusion of pleuroperitoneal canal, then there will be a defect on the left side of the posterolateral wall, and that is called as Boktalak hernia, and that is the cause. Basically, failure of fusion of pleuroperitoneal canal. ಇದರಿಂದಾಗಿ ಏನಾಗುತ್ತೆ, whatever the contents are there in the abdomen, that will get herniated through the left side into the thoracic cavity, leading to pushing whatever the structures are there in the thoracic cavity to right side. Okay na? So because of this ಏನಾಗುತ್ತೆ, there will be dyspnea, respiratory distress ಆಗುತ್ತೆ ಮಗುಗೆ. Other than that, shifting of heart to right side, that is called as dextrocardia. Other than that, whatever the abdomen is there, abdomen bulky ಕಾಣಿಸಲ್ಲ, ಅದು ಬಿಟ್ಬಿಟ್ಟು ಒಳ ಹೋಗಿರೋ ಥರ ಕಾಣಿಸುತ್ತೆ. If you are looking at it from the side, abdomen will look like this. It will look as if abdomen is inside. Scaphoid. So scaphoid bone ಕೂಡ ಹಿಂಗೆ ಇರೋದು ಸ್ಟ್ರಕ್ಚರ್. This is called as scaphoid. So scaphoid abdomen. These are the classical triad of congenital diaphragmatic hernia. If you see a baby in respiratory distress, and if you get a chest x-ray done, and if you see dextrocardia, and if there is scaphoid abdomen, then this is diagnostic of congenital diaphragmatic hernia. Okay. Other than that, bag and mask ventilation is contraindicated. ಯಾಕೆ ಏನಾಗುತ್ತೆ, bag and mask ventilation ಕೊಟ್ಟರೆ basically whatever we ventilate that will go into the lungs. Whatever the air we give through bag and mask ventilation, that will go into lungs. And if imagine this is the condition, and if lungs start expanding now, whatever the bowel is there already in the thoracic cavity, that will get compressed, and that will lead to ischemia or necrosis of these bowels also. So because of this, there will be bowel necrosis as well. Okay, so because there is a failure of fusion of pleuroperitoneal canal on the left side, whatever the left sided structures are there like spleen, stomach, transverse colon, these will herniate, and this will cause ipsilateral collapse of the lung and shifting of the heart to right side. This I have explained just now. Okay, so because of this, the left out space in the abdomen due to herniation causes the scaphoid abdomen. This is the triad of congenital diaphragmatic hernia: respiratory distress, dextrocardia, and scaphoid abdomen. Okay, so what is the most common cause of death is pulmonary hypoplasia. Andre lungs basically will start collapsing. If the collapse of the lung is not happening, then the baby will be surviving, otherwise it will lead to death of the baby. Okay, in case in bag and mask ventilation, there will be massive amount of air that will be collected in stomach as well. Okay na? So basically we are not pushing air only into the lungs, we are pushing air into the stomach as well, and stomach has herniated and it will start getting dilated. So there will be, if there is proper bag and mask ventilation, it should go to lungs, but some amount of air will also go to stomach as well. Because of that, there is increased risk, and hence it is contraindicated in case of congenital diaphragmatic hernia. So if you think the baby is in respiratory distress, and what do you think? Okay, we'll intubate or we'll give bag and mask ventilation and we'll resuscitate the baby and ಹೋಗ್ತೀವಿ. Before doing that, before doing bag and mask ventilation, we should rule out congenital diaphragmatic hernia. Only then we should go for bag and mask ventilation. Otherwise, we ourselves are killing the baby. Okay. So how will we diagnose this case? During pregnancy, mother will be experiencing polyhydramnios. Okay. So how is this interrelated? So ಏನಾಗುತ್ತೆ, whatever the amniotic fluid which is formed during pregnancy, okay na, this is formed from the kidneys of baby, and that will be through urination. Okay na, and then this itself, this amniotic fluid will be consumed by the baby. Okay, if the baby drinks this amniotic fluid, it will come down, correct? If the amniotic fluid is less, or basically 5 to 25 centimeters ಇರಬೇಕು amniotic fluid. If it is more than 25 centimeter, that means that the baby is not consuming. Why is the baby not consuming? Because of this congenital diaphragmatic hernia. Already hernia ಇರೋದ್ರಿಂದ ಏನಾಗುತ್ತೆ, baby bowel is not functioning that properly, and because of that it is not consuming. Esophagus and stomach is in a thoracic cavity. because of which the baby is not consuming amniotic fluid, and because of that amniotic fluid whatever is there, that is remaining in the amniotic sac itself, and that is leading to polyhydramnios. So during pregnancy, if the mother is having polyhydramnios, then one of the cause can be congenital diaphragmatic hernia. We should rule it out. Okay. After delivery, how can we diagnose it? We can do a chest X-ray. Chest X-ray ಮಾಡಿ ಏನು ಮಾಡ್ಬೋದು? We can see a gastric bubble in case of thorax. If the gastric bubble, it should be in the abdominal cavity. If it is there in the thorax, it is an indication that stomach is in thorax. That means congenital diaphragmatic hernia is there. Other than that, if there are presence of bowel loops in thorax, if stomach is there, gastric bubble will be there. If entire intestine has come, there will be bowel loops in thorax. After that, we can try inserting Ryle's tube, and that Ryle's tube, whatever is there, that will get coiled in the thorax, because whatever the Ryle's tube, it is nasogastric tube. We are inserting this tube into stomach, and where is the stomach now? It is in thorax. So what will it show? It will show coiling in case of thorax, and this is a diagnostic sign. Okay, so okay, now we have diagnosed it as congenital diaphragmatic hernia. How will we manage this case? Principle of management is basically to reduce the herniated organs back to the abdominal cavity. So whatever the structures have come here into the thoracic cavity, whatever the structures are here, this should be passed back into the abdominal cavity, and then we have to close the defect. That is the basic principle of management. So we'll reduce the herniated contents back into the abdominal cavity and close this defect by using a mesh, or if possible excision is done, or whatever the sac is there, that excision can be done. And mesh is not used in children because children will grow and this defect won't be of a particular size. It will start becoming big as the children grows. So mesh is not used usually. A prosthetic patch is used in case of large defects. Okay, na? Okay, so after this, Morgagni hernia. Just like I've said, it is also called as Larry's hernia, and it is usually right-sided or retrosternal. Just between sternum and diaphragm, there is a space. This is called as Larry's space, and hence the name Larry's hernia. So if the contents are herniating through this anterior retrosternal space, behind sternum, retrosternal space, so that is called as Morgagni hernia. It is in between the right side of the xiphoid process and central tendon of diaphragm, hence the shape is known as space of Larry. Okay, so ಇಲ್ಲಿ ಏನಾಗುತ್ತೆ, superior epigastric vessels are passing through this space. Whenever the content are coming from this space, there is a chance of involvement of superior epigastric vessels also. If there is why does this happen? If there is defective development of central tendon of diaphragm, then the space of Larry or Morgagni is enlarged, leading to high chances of herniation of even transverse colon, and it is usually most common on right side, whereas Bogdalek hernia is most common on left side. After this, most common herniated organ is transverse colon. Okay, illu management principle same, reduce the herniated organ, close the defect ashte. Okay, so we have discussed two important hernias, congenital diaphragmatic hernia. I want you to revise it again. So Bogdalek and Morgagni. Bogdalek is most common, and it is seen on the left side posterolateral, whereas this is seen in the right side usually and retrosternal. Okay, then what is the clinical feature here? Triad of CDH. ಎರಡರಲ್ಲೂ triad of CDH ಇರುತ್ತೆ, and after that we'll do X-ray, and then we'll come to know if it is Bogdalek or Morgagni. Okay, so clinical features ಎರಡಕ್ಕೂ same, that is triad. Respiratory distress syndrome, after that scaphoid abdomen. What was the other one? Dextrocardia. So this triad is seen in both. Management: put the abdominal organs back to the abdomen and close the defect. Because same. Okay, so this was about congenital diaphragmatic hernia. Then there is other hernia called hiatus hernia. Hiatus just means opening, and hernia through any opening is called hiatus hernia. Just like we know, there are certain openings in the diaphragm in all individuals, which is normal. Okay, ಇದು congenital diaphragmatic hernia because of improper closure of certain walls. So ಇದರಲ್ಲಿ improper closure of pleuroperitoneal canal. In case of Morgagni, it was improper closure of central tendon of diaphragm. ಇಲ್ಲಿ ಇಂಪ್ರಾಪರ್ ಕ್ಲೋಸರ್ ಇತ್ತು, ಎಂಬ್ರಿಯಾಲಜಿಕಲ್ ಡಿಫೆಕ್ಟ್ ಇತ್ತು, ಅದರಿಂದಾಗಿ ಹರ್ನಿಯಾ ಆಗ್ತಿತ್ತು. ಬಟ್ ಇನ್ ಕೇಸ್ ಆಫ್ hiatus hernia, it is normal opening present in every individual, and through those normal openings also there is herniation, and hence it is an acquired hernia, and it is common in adults and not in children. Okay, so now there are certain types of hiatal hernia. Type 1 is sliding hernia. It is the most common type. Okay, herniation of GE junction ಏನಾಗುತ್ತೆ, ಸ್ಲೈಡ್ ಆಗುತ್ತೆ. ಸೊ ಇಮ್ಯಾಜಿನ್ ದಿಸ್ ಇಸ್ diaphragm, this is esophagus, and then it continues as stomach, and then intestine. Okay na? So this will slide up. So this is the gastroesophageal junction, esophagus and stomach, adradu junction. So this will slide up, hence the name sliding hernia. So because of this there will be herniation of gastroesophageal junction. So type 2 is true paraesophageal hernia. It is a rolling hernia. Rolling andre enagutte, basically it is like this. The contents will roll up. So it is paraesophageal. ಇದರಲ್ಲಿ ಏನಾಗುತ್ತೆ, ಈ ಜಂಕ್ಷನ್ ಹಾಗೆ ಇರುತ್ತೆ. ವಾಟ್ ಎವರ್ ದಿಸ್ ಕಂಟೆಂಟ್ ಇಸ್ ದೇರ್, that will roll up. So gastroesophageal junction is normal and stomach has rollen up. So this is stomach. Esophagus is intact. ಅದಕ್ಕೆ ಇದನ್ನ ಟ್ರೂ ಪ್ಯಾರಾಇಸೋಫೇಜಿಯಲ್ ಹರ್ನಿಯಾ ಅಂತ ಕರೀತಾರೆ. ಓಕೆನಾ? ಸೊ ನೆಕ್ಸ್ಟ್ ಟೈಪ್ 3. ಇದರಲ್ಲಿ ಏನಾಗುತ್ತೆ, ಗ್ಯಾಸ್ಟ್ರೋಇಸೋಫೇಜಿಯಲ್ ಜಂಕ್ಷನ್ ಈಸ್ ಲೊಕೇಟೆಡ್ ಬಿಲೋ ಡಯಾಫ್ರಾಮ್, ವೆರಸ್ fundus of stomach has herniated and it is seen in the above the diaphragm. Okay, so type 3 is mixed paraesophageal. ಇದರಲ್ಲಿ ಏನಾಗುತ್ತೆ, both sliding and hernia. Gastroesophageal junction has also gone up, along with that the fundus of stomach has also gone up, that is both sliding and rolling. That is type 3. And type 4, it is paraesophageal hernia with herniation of content other than stomach. Along with stomach, some intestine part has also come, that is type 4. Hiatus hernia classification is easy. Type 1 is just sliding, just gastroesophageal junction has come up. If gastroesophageal junction is intact and fundus of stomach has herniated, then that is true paraesophageal hernia, that is type 2. If gastroesophageal junction both sliding and fundus of stomach has herniated, that is type 3. If along with fundus of stomach there is some part of the bowel other than stomach also, then that is type 4. Based on this, most common is sliding hernia and most common type of paraesophageal is type 3 mixed. ಆಯಿತಾ? ಸೊ ಸೈನ್ಸ್ ಆ್ಯಂಡ್ ಸಿಂಪ್ಟಮ್ಸ್ ಏನಿರುತ್ತೆ, ಟೈಪ್ 1 ಅಲ್ಲಾದರೆ ಜಸ್ಟ್ ಗ್ಯಾಸ್ಟ್ರೋಇಸೋಫೇಜಿಯಲ್ ಜಂಕ್ಷನ್ ಮೇಲೆ ಬಂದಿದೆ, ಸೊ ಹಿಲ್ ಬಿ ಜಸ್ಟ್ ಹ್ಯಾವಿಂಗ್ ರಿಫ್ಲಕ್ಸ್ ಆಫ್ ಫುಡ್, ತುಂಬ ತೇಗ್ ಬರೋದು, ಹುಳಿ ತೇಗ್ ಬರೋದು, ಈ ಥರ ಆಗ್ತಿರುತ್ತೆ ಅಷ್ಟೇ. ಸೊ ಟೈಪ್ 2 ಇಸ್ herniation of fundus of the stomach which can lead to ischemia and hence cause abdominal pain because there is only slight hole. So through this narrow hole only entire stomach has gone. Because of that there will be constriction at this region and this can go to ischemia and necrosis, because of which there will be abdominal pain. So type 3, since it is both sliding, so type 1 the symptom barutte and type 2 the symptom barutte. So it is both reflux and abdominal pain. Type 4, it will be highest risk of ischemia and strangulation because including stomach, intestine has come. So abdominal pain and increased risk of other complications will be there. So how will we diagnose this? Basically investigation of choice is barium swallow. We'll give the patient barium and ask him to swallow along with some liquid water or something, 1 liter of water I think, and we'll take serial x-rays. Since barium can be seen on x-ray, we can visualize the structures and say if there is hiatal hernia. What will be the treatment after we diagnose hiatal hernia? We'll go by laparoscopic route and or we can repair via abdominal route. ಬೇಸಿಕಲಿ ವಿಲ್ ಪುಲ್ ಬ್ಯಾಕ್ ದ ಸ್ಟ್ರಕ್ಚರ್ಸ್ ವಾಟ್ ಎವರ್ ಹ್ಯಾವ್ ಹರ್ನಿಯೇಟೆಡ್. ಇವಾಗ ಅಬ್ಡಾಮಿನಲ್ ರೂಟಿಂದ ಬೇಕಾದ್ರೆ ಹೋಗಿ ಇದನ್ನು ಪುಲ್ ಮಾಡ್ಬೋದು, ಇಲ್ಲ ಲ್ಯಾಪ್ರೋಸ್ಕೋಪಿಕಲ್ ರೂಟಲ್ಲಿ ಹೋಗಿ ಇದನ್ನು ಪುಷ್ ಮಾಡ್ಬೋದು. ಸೊ ಬೇಸಿಕಲಿ ರಿಡಕ್ಷನ್ ಆಫ್ ದ ಕಂಟೆಂಟ್ಸ್ ಇಸ್ ದ ಮೇನ್ ಪ್ರಿನ್ಸಿಪಲ್ ಎವ್ರಿವೇರ್. ಓಕೆ, ಇದಾದಮೇಲೆ ದೇ ಹ್ಯಾವ್ ಜಸ್ಟ್ explained about sliding hernia and stress ulcers. Okay, I'll skip this. So normal anatomy ನಾವು ಇದುವರೆಗೂ esophagus ಬಗ್ಗೆ ಒಂದಷ್ಟು ಡಿಸ್ಕಸ್ ಮಾಡಿದ್ವಿ. We should know that esophagus has two sphincters, one at the upper end, upper esophageal sphincter, and other one at the lower end, that is lower esophageal sphincter. And the length of esophagus is 25 centimeter. ಸೊ ಈ 25 ಸೆಂಟಿಮೀಟರ್ಸ್ ಅಲ್ಲಿ ಅದ್ರ ಜೊತೆಗೆ ದೇರ್ ಆರ್ ಸ್ಪಿಂಕ್ಟರ್ಸ್. ಬೇಸಿಕಲಿ ದೀಸ್ ಆರ್ ಮಸ್ಕ್ಯುಲರ್ ಸಪೋರ್ಟ್ಸ್ ವಿಚ್ ವಿಲ್ ಹೆಲ್ಪ್ ಇನ್ ಯೂನಿಡೈರೆಕ್ಷನಲ್ ಫ್ಲೋ ಆಫ್ ಫುಡ್. ಮೌತಿಂದ ಸ್ಟಮಕ್ಗೆ ಹೋಗ್ಬೇಕಷ್ಟೆ, ಇಟ್ ಶುಡ್ ನಾಟ್ ಬಿ ರಿವರ್ಸ್. ಫಾರ್ ದ್ಯಾಟ್, ಎನ್ಶೂರಿಂಗ್ ದ್ಯಾಟ್ ಯೂನಿಡೈರೆಕ್ಷನಲ್ ಫ್ಲೋ ಆಫ್ ಫುಡ್ ಅಕರ್ಸ್, ದೇರ್ ಆರ್ ಟೂ ಸ್ಪಿಂಕ್ಟರ್ಸ್. upper esophageal sphincter is usually 4 to 5 centimeter, whereas lower esophageal sphincter is 5 centimeters. Okay, and this is usually intra-abdominal, and ಇಲ್ಲೇನಾಗುತ್ತೆ, ಡಯಾಫ್ರಾಮ್ ಇದ್ರ ಮಧ್ಯದಲ್ಲಿ ಬರುತ್ತೆ ಲೈಕ್ ದಿಸ್. ಓಕೆ, ಸೊ ಮೇಲ್ಗಡೆ 3 ಸೆಂಟಿಮೀಟರ್ ಇದೆ, ಕೆಳಗಡೆ 2 ಸೆಂಟಿಮೀಟರ್ ಇದೆ. ಇಂಟ್ರಾ ಅಬ್ಡಾಮಿನಲ್ ಲೆಂತ್ ಇಸ್ 2 ಸೆಂಟಿಮೀಟರ್ ಆ್ಯಂಡ್ ಅಬವ್ ಇಸ್ 3 ಸೆಂಟಿಮೀಟರ್. ಓಕೆ, ನಾರ್ಮಲಿ ಪ್ರೆಷರ್ ಇನ್ ದ ಅಪ್ಪರ್ esophageal sphincter is 60 mmHg and in the lower one is less, that is 6 to 26. And usually the upper esophageal sphincter, just like I said, it is usually skeletal muscle ಇರುತ್ತೆ ಮೇಲ್ಗಡೆ, ಲೋವರ್ ಅಲ್ಲಿ ಸ್ಮೂತ್ ಮಸಲ್ ಇರುತ್ತೆ, ಮಧ್ಯದಲ್ಲಿ there will be transition. So since upper esophageal sphincter has skeletal muscles, it will be having distal part of inferior pharyngeal constrictor, cricopharyngeus, and some proximal circular muscles of proximal esophagus. So these will be the muscles which are skeletal muscles that will help in managing the passage of food. Okay, in case of lower esophageal sphincter, we need to study a bit more because there are some certain specific diseases related to lower esophageal sphincter as well. So just like I have said, there is less pressure in case of lower esophageal sphincter as compared to upper esophageal sphincter, that is 6 to 26 mm of Hg. So there are factors which will decrease this pressure as well. What are those factors that will decrease the pressure? There are certain drugs like prostaglandins, morphine, theophylline, barbiturates, diazepam, calcium channel blockers, atropine, nitrates, etc. And there are certain foods which will decrease the pressure in lower esophageal sphincter, like coffee, alcohol, peppermint, smoking, fat. ಬೇಸಿಕಲಿ ಇವೆಲ್ಲ ಡಿಕ್ರೀಸ್ ಮಾಡಿದರೆ ಏನಾಗುತ್ತೆ, ಸೊ ದೇರ್ ಶುಡ್ ಬಿ ಸರ್ಟನ್ ಅಮೌಂಟ್ ಆಫ್ ಪ್ರೆಷರ್ ಸೊ ದ್ಯಾಟ್ ಇಟ್ ಈಸ್ ಕ್ಲೋಸ್ಡ್, ಆ್ಯಂಡ್ ಓನ್ಲಿ ಇಫ್ ದ ಪ್ರೆಷರ್ ಈಸ್ ಮೋರ್ ದ್ಯಾನ್ 6 to 26 mmHg, ಓನ್ಲಿ ದೆನ್ ದಿಸ್ ಲೋಯರ್ esophageal sphincter will open and food will enter the stomach. ಆಯಿತಾ? ಬಟ್ ವಾಟ್ ದೀಸ್ ಸರ್ಟನ್ ಫುಡ್ಸ್ will do is, this will reduce this pressure. So there will be laxity in this pressure and there will be no unidirectional flow. ರಿಫ್ಲಕ್ಸ್ ಆಗೋದೆಲ್ಲ ಜಾಸ್ತಿ ಆಗುತ್ತೆ ಇಫ್ ದ ಪ್ರೆಷರ್ ರೆಡ್ಯೂಸಸ್. ಬೇಸಿಕಲಿ ಅಷ್ಟೇ ಪಾಯಿಂಟ್. If the lower esophageal sphincter pressure is less, there will be increased chances of reflux. Okay, na? So basically you can use this food. Gastritis cause ಮಾಡೋದು ಏನು ಅಂತ ಕೇಳಿದ್ರೆ, you can say this because chocolate or coffee excessive consumption, alcohol excessive consumption ಮಾಡಿದರೆ, peppermint, smoking ಜಾಸ್ತಿ ಮಾಡಿದರೆ, and if you are eating fatty food, then these will cause gastritis, or these will basically ಹೆಂಗೆ ಕಾಸ್ ಮಾಡೋದು ಗ್ಯಾಸ್ಟ್ರೈಟಿಸ್ ಅಂದರೆ, ಇಟ್ ಈಸ್ ರೆಡ್ಯೂಸಿಂಗ್ ದ ಲೋಯರ್ esophageal sphincter pressure, because of which there is increased chances of gastritis. Okay, so you need to avoid this food to avoid gastritis, and other than that these are the drugs. Okay, so if we are giving these drugs, we'll be adding some proton pump inhibitor or ಈ ಥರದ್ದೇನಾದರೂ, like basically to avoid gastritis. Okay, na? So what happens if there is an incompetent lower esophageal sphincter? ಇದರಲ್ಲಿ ಬರೀ ಪ್ರೆಷರ್ ವೇರಿ ಆಗಿದ್ದಕ್ಕೆ ರಿಫ್ಲೆಕ್ಸ್ ಆಗುತ್ತೆ ಅಂತ ಹೇಳಿದೆ. ಇಫ್ ಇಟ್ ಈಸ್ ಟೋಟಲಿ ಇನ್ಕಾಂಪಿಟೆಂಟ್ ಏನಾಗುತ್ತೆ, ದೇರ್ ವಿಲ್ ಬಿ GERD ಅಷ್ಟೇ, ಗ್ಯಾಸ್ಟ್ರೋ ಈಸೋಫೇಜಿಯಲ್ ರಿಫ್ಲಕ್ಸ್ ಡಿಸೀಸ್. ಸೊ ಗ್ಯಾಸ್ಟ್ರಿಕ್ ಅಂದರೆ ಸ್ಟೊಮಕ್ ಇಂದ ಈಸೋಫೆಗಸ್ಗೆ ರಿಫ್ಲಕ್ಸ್ ಆಗ್ತಿದೆ, ದಟ್ ಈಸ್ GERD. ಇದರಲ್ಲಿ ಏನಾಗುತ್ತೆ, ವಾಟ್ ಈಸ್ ದ ಸೀಕ್ವೆನ್ಸ್ ಆಫ್ ಇವೆಂಟ್ಸ್ ದಟ್ ವಿಲ್ ಟೇಕ್ ಪ್ಲೇಸ್ ಅಂತ. ದೇರ್ ವಿಲ್ ಬಿ ರಿಫ್ಲಕ್ಸ್ ಆಫ್ ಗ್ಯಾಸ್ಟ್ರಿಕ್ ಕಂಟೆಂಟ್ ಟು ಈಸೋಫೆಗಸ್. ಸೊ ಏನಾಗುತ್ತೆ, ವಾಟ್ ಎವರ್ ದ esophagus is there, that is not meant for digestion. It will just go and irritate the esophagus, and that will cause inflammation of esophagus called as esophagitis. ಅದರಿಂದಾಗಿ ಏನಾಗುತ್ತೆ, ಕಂಟಿನ್ಯೂಸ್ ಹೋಗಿ ಇರಿಟೇಟ್ ಮಾಡಿ 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 ಇಟ್ ವಿಲ್ ಗೋ ಆ್ಯಂಡ್ ಕಾಸ್ ಅಲ್ಸರ್ಸ್ ಇನ್ esophagus. ಆ್ಯಂಡ್ ಅಲ್ಸರ್ಸ್ ಆದರೆ ಏನಾಗುತ್ತೆ, ಇಟ್ ಈಸ್ ಬೇಸಿಕಲಿ ಅ ವೂಂಡ್. a wound will heal by fibrosis, and because of this there will be stricture. The esophagus will now become fibrosed and it will become much more narrow. This part of esophagus has undergone fibrosis, and then it had led to stricture formation, and then it can be replaced by the whatever the lining epithelium of stomach is there or intestine is there, that will replace the lining of the esophagus. ನಾನು ಸ್ಟಾರ್ಟಿಂಗ್ ಹೇಳಿದಾಗ ಏನು ಹೇಳಿದೆ, ಲೈನಿಂಗ್ ಆಫ್ esophagus is stratified squamous non-keratinized epithelium. This will get changed to whatever the stomach ಇಂದ ಹೋಗ್ತಾ ಇದೆ ಅಲ್ವಾ ಕಂಟೆಂಟ್ಸ್, ಸೊ ಸ್ಟೊಮಕ್ ಎಪಿಥೀಲಿಯಮ್ ದಟ್ ಈಸ್ columnar ಆಗಿ ಕನ್ವರ್ಟ್ ಆಗುತ್ತೆ. This is basically adaptation in order to avoid that irritation by food, but this is dangerous and that can lead to cancer of esophagus, that is increased risk of adenocarcinoma. And this mechanism, or if the lining epithelium of the esophagus is changed from stratified squamous to columnar, this is called as Barrett's esophagus, and this is also a disease. If we see Barrett's esophagus, then there is high chance that the patient will go for carcinoma of the esophagus, that is increased risk for adenocarcinoma ಇದೆ ಅಂತ. ಅಲ್ಲಿಗೆ Barrett's esophagus ಫಾರ್ಮ್ ಆಗಿದೆ ಅಂದರೆ there is a long term exposure or there is a long term GERD which is happening here, and that has led to the formation of Barrett's esophagus. So what will be the clinical features in case of GERD? Classical triad, reflux ಜಾಸ್ತಿ ಆಗ್ತಿದೆ, so heart burns, epigastric pain and regurgitation. These are the classical triad. Most commonly, what will be the presentation of the patient? With long standing heartburn, along with that there will be history of regurgitation. So how will we diagnose this case? Investigation of choice is 24-hour ambulatory pH monitoring ಅಂತ ಕರಿತೀವಿ. 24-hour ambulatory pH monitor. ಎಲ್ಲಿ ಮಾನಿಟರ್ ಮಾಡ್ತೀವಿ ಪಿ ಎಚ್ನ? ಇನ್ ದ ಲೋವರ್ ಈಸೋಫೆಗಸ್, ಲೋವರ್ ಪಾರ್ಟ್ ಆಫ್ ದ ಈಸೋಫೆಗಸ್ ಅಲ್ಲಿ ಪಿ ಎಚ್ನ ಮೆಜರ್ ಮಾಡಬೇಕು. ಇಫ್ ಇಟ್ ಟರ್ನ್ಸ್ ಅಸಿಡಿಕ್ ಬಿಕಾಸ್ ಆಫ್ ಗ್ಯಾಸ್ಟ್ರಿಕ್ ಕಂಟೆಂಟ್ಸ್, ಇಟ್ ವಿಲ್ ಟರ್ನ್ ಅಸಿಡಿಕ್ ಇನ್ ಕೇಸ್ ಆಫ್ GERD. So this will confirm that if there is acidic pH in case of esophagus, then it is GERD confirmed. ಆಯಿತಾ? ಇದನ್ನು ಡಿ-ಮೀಸ್ಟರ್ಸ್ ಸ್ಕೋರ್ ಅಂತ ಯೂಸ್ ಮಾಡ್ತೀವಿ. ದಟ್ ಈಸ್ ನಾರ್ಮಲ್ ಈಸ್ ಲೆಸ್ ದ್ಯಾನ್ 14.7. ಇಫ್ ಇಟ್ ಈಸ್ ಮೋರ್ ದ್ಯಾನ್ 14.7, ಇಟ್ ಇಂಡಿಕೇಟ್ಸ್ ದಟ್ gastritis or GERD is there. So how will we manage once it is confirmed? Lifestyle modification first, like whatever the substances I have told that will reduce lower esophageal sphincter pressure alla, like smoking, fatty contents, caffeine or coffee or chocolate, ಇದೆಲ್ಲ ಅವಾಯ್ಡ್ ಮಾಡೋಕ್ಕೆ ಹೇಳ್ತೀವಿ. Cessation of smoking, decrease caffeine intake, avoid large meals that contain fat. So this is lifestyle modification. After that we'll put him on double dose of proton pump inhibitors like omeprazole, pantoprazole. This is double dose, ಬೆಳಗ್ಗೆ ಒಂದು ರಾತ್ರಿ ಒಂದು ಅಥವಾ 2 tablets at a time ಈ ಥರ. Okay, then before performing surgery, if before performing surgery, following investigations should be mandatory in case of GERD. That is 24-hour ambulatory pH monitoring, ಅದಾದಮೇಲೆ barium swallow to rule out sliding hernia, and endoscopy or biopsy, endoscopy with biopsy to rule out there is no columnar metaplasia or there is no Barrett's esophagus. If ಮೂರನ್ನು ಕನ್ಫರ್ಮ್ ಮಾಡಾದ್ಮೇಲೆ we should take for surgery, otherwise we should not take. In gold standard treatment ಏನು ಸರ್ಜರಿ, that is laparoscopic Nissen's fundoplication. ಏನು fundoplication ಅಂದರೆ ಫಂಡೋ ಮೀನ್ಸ್ ಫಂಡಸ್ ಆಫ್ ಸ್ಟೊಮಕ್, ಕರೆಕ್ಟಾ? ಇಲ್ಲೇನಾಗ್ತಿದೆ, ರಿಫ್ಲೆಕ್ಸ್ ಆಗ್ತಿದೆ ಬಿಕಾಸ್ ಆಫ್ ಇನ್ಕಾಂಪಿಟೆಂಟ್ ಲೋಯರ್ ಇಸೋಫೆಜಿಯಲ್ ಸ್ಪಿಂಕ್ಟರ್. ಸೊ ಈ ಲೋಯರ್ ಇಸೋಫೆಜಿಯಲ್ ಸ್ಪಿಂಕ್ಟರ್ನ ನಾವೇನಾದರೂ ಮಾಡಿ ಎಲಿಮಿನೇಟ್ ಮಾಡಿ ಇದ್ರ ಫಂಕ್ಷನ್ ಕಾಸ್ ಮಾಡಬೇಕು, ಇದ್ರ ಫಂಕ್ಷನ್ನ ಬೇರೆದೇನಾದ್ರು ಮಾಡೋ ಥರ ಮಾಡಬೇಕಷ್ಟೇ ನಾವು. ಬಿಕಾಸ್ ಫಾರ್ ದ್ಯಾಟ್ ಇಟ್ ಈಸ್ ಕಾಲ್ಡ್ ಎಸ್ ಫಂಡೋಪ್ಲೈಕೇಶನ್. ಈಸೋಫೆಗಸ್ ಹಿಂಗಿದೆ, ಫಂಡಸ್ ಆಫ್ ಸ್ಟೊಮಕ್ ಇಸ್ ಟೇಕನ್ ಆ್ಯಂಡ್ ಇಟ್ ಈಸ್ ಲೈಗೇಟೆಡ್ ಆರ್ ಪ್ಲೈಕೇಟೆಡ್ ವಿತ್ ಈಸೋಫೆಗಸ್ ಅಷ್ಟೇ. ಸೊ ಜಸ್ಟ್ ಲೈಕ್ ವಿ ಕ್ಯಾನ್ ಸಿ ದಿಸ್ ಇಸ್ ಈಸೋಫೆಗಸ್ ಆ್ಯಂಡ್ ದ ಫಂಡಸ್ ಆಫ್ ದ ಸ್ಟೊಮಕ್ ಈಸ್ sutured to esophagus. That is called as fundoplication. ಇದರಲ್ಲಿ ಬೇರೆ ಬೇರೆ ಥರ ಇದೆ. 360 ಡಿಗ್ರಿ ಅಂದರೆ ಎಂಟೈರ್ ಈಸೋಫೆಗಸ್ಸು, ಎಂಟೈರ್ ಈಸೋಫೆಗಸ್ ಇಸ್ ಕವರ್ಡ್ ಬೈ ಫಂಡಸ್ ಆಫ್ ದ ಸ್ಟಮಕ್. ಸೊ ದಿಸ್ ಈಸ್ 360 ಡಿಗ್ರಿ. That is called as Nissen's fundoplication. There are other types where only 90 degree, ಬರೀ anterior part of the fundus of stomach is sutured with ಏನಂತಾರೆ esophagus. Then that is Watson fundoplication. If it is Dorr fundoplication, 180 degree ಇದನ್ನು ಕವರ್ ಮಾಡ್ತೀವಿ ಅಷ್ಟೇ, ಲೈಕ್ ಒನ್ ಸೈಡ್, ಇನ್ನು ಆಪೋಸಿಟ್ ಸೈಡು ಇಟ್ ಈಸ್ ಲೆಫ್ಟ್. ಸೊ ದಿಸ್ ಈಸ್ ಡಾರ್ಸ್ ಫಂಡೋಪ್ಲೈಕೇಶನ್ ಆ್ಯಂಡ್ 180 ಡಿಗ್ರಿ ಆ್ಯಂಟೀರಿಯರ್ಲಿ ಕವರ್ ಮಾಡ್ತೀವಿ. ಟೋಪೆ ಫಂಡೋಪ್ಲೈಕೇಶನ್ ಅಂದರೆ 270 ಡಿಗ್ರಿ ಫ್ರಮ್ ಬಿಹೈಂಡ್ ಪೋಸ್ಟೀರಿಯರ್ಲಿ. ಬರೀ ಆ್ಯಂಟೀರಿಯರ್ದು ಸ್ವಲ್ಪ 90 ಡಿಗ್ರಿ ಮಾತ್ರ ಓಪನ್ ಇರುತ್ತೆ. ದೆನ್ ಬೆಲ್ಸಿ ಮಾರ್ಕ್ ಅಂದರೆ 270 ಡಿಗ್ರಿ ಆಫ್ ಈಸೋಫೆಗಸ್ ಆ್ಯಂಟೀರಿಯರ್ಲಿ, ಜಸ್ಟ್ ಆಪೋಸಿಟ್ ಟು ಟೋಪೆ ಫಂಡೋಪ್ಲಿಕೇಶನ್. ಇನ್ ದಿ ಸೆನ್ಸ್ ಫಂಡೋಪ್ಲಿಕೇಶನ್ ಜಸ್ಟ್ ಲೈಕ್ ಎ ಸೆಡ್ ಎಂಟೈರ್ ಈಸೋಫೆಗಸ್ ಆ್ಯಂಡ್ ಫಂಡಸ್ ಈಸ್ ಸೂಚರ್ಡ್. ಓಕೆನಾ? ಸೊ ಮೋಸ್ಟ್ ಕಾಮನ್ಲಿ ಪರ್ಫಾರ್ಮ್ ಪ್ರೊಸೀಜರ್ ಯಾವುದಂದ್ರೆ ನಿಸನ್ಸ್, ದಟ್ ಈಸ್ 360 ಡಿಗ್ರಿ ಆ್ಯಂಡ್ ರೇರ್ಲಿ ಪರ್ಫಾರ್ಮ್ಡು ಈ 90 ಡಿಗ್ರೀಸು ಆ್ಯಂಡ್ ದಿಸ್ 270 ಡಿಗ್ರಿ ಆ್ಯಂಟೀರಿಯರ್ಲಿ. ಸೊ ಬೇಸಿಕಲಿ ಫಂಡೋಪ್ಲಿಕೇಶನ್ ರಿಲೇಟೆಡ್ ಏನಾದರೂ ನೆನ್ಪಿಟ್ಕೋಬೇಕು ಅಂತಿದ್ದರೆ ನಿಮಗೆ, ಯು ಶುಡ್ ರಿಮೆಂಬರ್ ನಿಸನ್ಸ್ ಫಂಡೋಪ್ಲಿಕೇಶನ್, ದಟ್ ಈಸ್ 360 ಡಿಗ್ರಿ, ಡಾರ್ ಫಂಡೋಪ್ಲಿಕೇಶನ್ ಆ್ಯಂಡ್ ಟೂಪೆ ಫಂಡೋಪ್ಲಿಕೇಶನ್. ಡಾರ್ ಈಸ್ 90 ಡಿಗ್ರಿ ಆ್ಯಂಟೀರಿಯರ್ಲಿ, ಟೂಪೆ ಈಸ್ 270 ಡಿಗ್ರಿ posteriorly. Correct ಅಲ್ಲ? ಓಕೆ, ಸಾರಿ, ಡಾರ್ is 180 degree anteriorly. ಓಕೆ, ಸೊ 360, 180 and 270 degrees ಇಷ್ಟು ನೆನ್ಪಿಟ್ಕೋಬೇಕು. ಡಾರ್, ಟೂಪೆ ಆ್ಯಂಡ್ ನಿಸೆನ್ಸ್ ಫಂಡೋಪ್ಲಿಕೇಶನ್. ಸೊ ದಿಸ್ ಈಸ್ ಅಬೌಟ್ GERD. ಓಕೆ, ಲೋಯರ್ ಈಸೋಫೆಗಲ್ ಸ್ಪಿಂಕ್ಟರ್ ಇನ್ಕಾಂಪಿಟೆಂಟ್ ಆದರೆ ಇಟ್ ವಿಲ್ ಕಾಸ್ ದಿಸ್ ಡಿಸೀಸ್ ಅಂತ ಗೊತ್ತಾಯಿತು. ಅಪ್ಪರ್ ಈಸೋಫೆಗಲ್ ಸ್ಪಿಂಕ್ಟರಲ್ ಪ್ರಾಬ್ಲಮ್ ಇದ್ರೆ ಏನಾಗುತ್ತೆ? ಇಟ್ ಈಸ್ ಕಂಪೋಸ್ಡ್ ಆಫ್ ಆಬ್ಲಿಕ್ ಫೈಬರ್ಸ್ ಆಫ್ ಬೇಸಿಕಲಿ ಸ್ಕೆಲಿಟಲ್ ಮಸಲ್ಸ್ ಇದೆ ಇಲ್ಲಿ, ಆ್ಯಂಡ್ ದೇರ್ ಕ್ಯಾನ್ ಬಿ ಅ ಗ್ಯಾಪ್ ಬಿಟ್ವೀನ್ ದೀಸ್ ಸ್ಕೆಲಿಟಲ್ ಮಸಲ್ಸ್. ದ್ಯಾಟ್ ಗ್ಯಾಪ್ ಈಸ್ ಕಾಲ್ಡ್ ಅಸ್ ಕಿಲಿಯನ್ಸ್ ಡೆಹಿಸೆನ್ಸ್. ಆಯಿತಾ? ದಿಸ್ ಕ್ಯಾನ್ ಲೀಡ್ ಟು ಈಸೋಫೆಜಿಯಲ್ ಡೈವರ್ಟಿಕ್ಯುಲ ಆರ್ ದೇರ್ ಕ್ಯಾನ್ ಬಿ ಝೆಂಕಸ್ ಡೈವರ್ಟಿಕ್ಯುಲಮ್. ಹೆಂಗಾಗುತ್ತೆ ಅಂದರೆ, ಇವಾಗ ದೇರ್ ಆರ್ ಟ್ರಾನ್ಸ್ವರ್ಸ್ ಮಸಲ್ ಫೈಬರ್ಸ್ ಆಫ್ ಕ್ರಿಕೋಫ್ಯಾರಿಂಗ್ಸ್. ಓಕೆನಾ? And then starts thyropharynx. Basically we are seeing it from posterior side. ಹಿಂದೆಯಿಂದ ನೋಡ್ತಾ ಇದ್ದೀವಿ, ಈ ಥರ ಜಾಯಿನ್ ಆಗಿ ಈಸೋಫೆಗಸ್ ಫಾರ್ಮ್ ಆಗ್ತಿರುತ್ತೆ. ಆಯಿತಾ? ಸೊ ಈಸೋಫೆಗಸಲ್ಲಿ ಏನಾಯಿತು, ಈ ಕ್ರಿಕೋಫ್ಯಾರಿಂಗ್ಸು ಮತ್ತು ಥೈರೋಫ್ಯಾರಿಂಗ್ಸ್ ಎರಡು ಮಸಲ್ ಮಧ್ಯೆ ಗ್ಯಾಪ್ ಉಳಿತು. ದಿಸ್ ಗ್ಯಾಪ್ ಈಸ್ ಅ ಡಿಫೆಕ್ಟ್. ಬೇಸಿಕಲಿ ಇಲ್ಲಿಂದ ಫುಡ್ಡು ಇದು ಏನು ಬೇಕಾದರೂ ಹರ್ನಿಯೇಟ್ ಆಗ್ಬೋದು. ಅದು ಹರ್ನಿಯೇಟ್ ಆದರೆ ಹೆಂಗೆ ಕಾಣಿಸುತ್ತೆ? ಈ ಥರ ಕಾಣಿಸುತ್ತೆ. ಆ್ಯಂಡ್ ದ್ಯಾಟ್ ಈಸ್ ಕಾಲ್ಡ್ ಅಸ್ ಝೆಂಕಸ್ ಡೈವರ್ಟಿಕ್ಯುಲಮ್. ದಿಸ್ ಡೈವರ್ಟಿಕ್ಯುಲಮ್ posteriorly, which is due to defect between cricopharynx and thyropharynx muscles, is called as Killian's dehiscence. And if there is a diverticulum of esophagus happening from there, that is called as Zenker's diverticulum. Okay, ಅದು ಬಿಟ್ಟರೆ ಅದರ್ ಈಸೋಫೆಜಲ್ ಡೈವರ್ಟಿಕ್ಯುಲ ಇದು ಅಷ್ಟು ಇಂಪಾರ್ಟೆಂಟ್ ಇಲ್ಲ. ಝೆಂಕಸ್ ಡೈವರ್ಟಿಕ್ಯುಲಮ್ ಒಂದು ಇಂಪಾರ್ಟೆಂಟ್, ಅದನ್ನು ನೆನ್ಪಿಟ್ಕೊಳ್ಳಿ ಸಾಕು. ಸೊ ಓಕೆ, ನಾನು ಉಲ್ಟಾ ಬರ್ದಿದ್ದೀನಿ ಪ್ರಾಬಬ್ಲಿ. ಫ್ರಮ್ ಬಿಹೈಂಡ್ ವಿ ಆರ್ ಸೀಯಿಂಗ್ ಅಲ್ಲ, ದಿಸ್ ಇಸ್ ಥೈರೋಫ್ಯಾರಿಂಕ್ಸ್ ಮಸಲ್ಲು, ದಿಸ್ ಇಸ್ ಕ್ರಿಕೋಫ್ಯಾರಿಂಕ್ಸ್ ಮಸಲ್. ಸೊ ದೇರ್ ಈಸ್ ಅ ಡಿಫೆಕ್ಟ್ ವಿಚ್ ಇಸ್ ದಿಸ್ ಡಿಫೆಕ್ಟ್, ಟ್ರಯಾಂಗ್ಯುಲರ್ ಡಿಫೆಕ್ಟ್. ಆ ಟ್ರಯಾಂಗ್ಯುಲರ್ ಡಿಫೆಕ್ಟಿಂದ ಈ ಥರ ಝೆಂಕಸ್ ಡೈವರ್ಟಿಕ್ಯುಲಮ್ ಆಗುತ್ತೆ. ಓಕೆ, ಸೊ ವಾಟ್ ಈಸ್ ಅ ಟ್ರೂ ಡೈವರ್ಟಿಕ್ಯುಲಮ್ ಆ್ಯಂಡ್ ವಾಟ್ ಈಸ್ ಅ ಫಾಲ್ಸ್ ಡೈವರ್ಟಿಕ್ಯುಲಮ್ ಅಂತ ಕೇಳ್ಬೋದು. ಝೆಂಕಸ್ ಡೈವರ್ಟಿಕ್ಯುಲಮ್ ಇಸ್ ಅ ಫಾಲ್ಸ್ ಡೈವರ್ಟಿಕ್ಯುಲಮ್. ಇಷ್ಟು ನೆನಪಿರಬೇಕು. ಏನು ಫಾಲ್ಸ್ ಅಂದರೆ, ದೇರ್ ಈಸ್ ಓನ್ಲಿ ಹರ್ನಿಯೇಷನ್ ಆಫ್ ಮ್ಯೂಕೋಸಾ ಆ್ಯಂಡ್ ಸಬ್ಮ್ಯೂಕೋಸಾ ಅಷ್ಟೇ. ಬಟ್ ಇಫ್ ಎಂಟೈರ್ ವಾಲ್, ಆಲ್ ದ ಲೇಯರ್ಸ್ ಆಫ್ ದ GIT, ದಟ್ ಈಸ್ ಮ್ಯೂಕೋಸಾ, ಸಬ್ಮ್ಯೂಕೋಸಾ, ಮಸ್ಕ್ಯುಲರ್ ಸೆಕ್ಷನ್ನ ಎಲ್ಲ ಈ ಹರ್ನಿಯಾ ಒಳಗಿಂದ ಬಂದರೆ ಓನ್ಲಿ ದೆನ್ ಇಟ್ ಈಸ್ ಕಾಲ್ಡ್ ಅಸ್ ಟ್ರೂ ಡೈವರ್ಟಿಕ್ಯುಲಮ್. ಸೊ ಇವಾಗ ಬೇಸಿಕಲಿ ಮ್ಯೂಕೋಸಾ, ಸಬ್ಮ್ಯೂಕೋಸಾ ಆ್ಯಂಡ್ ಮಸ್ಕ್ಯುಲರ್ ಸೆಕ್ಷನ್ನ ಎಲ್ಲ ಇದರೊಳಗಿಂದ ಬಂದರೆ ಅಷ್ಟೇ, ದಟ್ ಈಸ್ ಟ್ರೂ. Zenker's diverticulum only, only mucosa and submucosa will come, hence it is a false diverticulum. So we need to know about Zenker's diverticulum. It is most common esophageal diverticula, and it is a false diverticulum because only mucosa and submucosa will be herniating through it. It is most commonly seen in elderly, diabetics and in males. So ಇಲ್ಲಿ ಏನಾಗುತ್ತೆ, inferior constrictor muscle has dual nerve supply, that is thyropharyngeus. That muscle which we saw above ಅಲ್ವಾ, ಮೇಲಿಂದ ಹಿಂಗೆ ಬರ್ತಿರೋದು, this thyropharyngeus is supplied by pharyngeal plexus, whereas the cricopharynx, which is a horizontal muscle, that is supplied by recurrent laryngeal nerve. So ಎರಡಕ್ಕೂ ಬೇರೆ ಬೇರೆ nerve supply ಇದೆ. ಮೇಲ್ಗಡೆ ಇರೋ ಮಸಲ್ಗೆ ಆ್ಯಂಡ್ ಕೆಳಗಡೆ ಇರೋ ಮಸಲ್ಗೆ. ಓಕೆನಾ? ಸೊ ಬೋತ್ ಹ್ಯಾವ್ two different nerve supply. So this nerve can act at one time and this nerve can act at one time, which will lead to variation in the nerve supply. Because of this neuromuscular incoordination ಆಗುತ್ತೆ, ಅಷ್ಟು ಒಳ್ಳೆ ಕಾಂಬಿನೇಷನ್ ಇರಲ್ಲ. ಸೊ ದಿಸ್ ವಿಲ್ ಕಾಂಟ್ರಾಕ್ಟ್ ಅಟ್ ಒನ್ ಟೈಮ್ and this will contract at other time. In case of elderly or diabetics or males, there is difference in contraction period of these both muscles, because of which there will be passage of food into, or esophagus will be pushed through this wall like this. ಆಯಿತಾ? ಇದು ಮೇಲ್ಗಡೆ ಇರೋದು inferior constrictor muscle, and this is cricopharynx. Between them there is a diverticula where esophagus is pushed through that defect. This is called as Zenker's diverticulum. And ಇಲ್ಲಿ esophagus ಆಗಿರೋದ್ರಿಂದ whatever the food we consume through the mouth, it will come and get accumulated in this region, and because of this it is not undergoing digestion also. ಇಲ್ಲೇ accumulate ಆಗಿ ಏನಾಗುತ್ತೆ, ಬ್ಯಾಡ್ ಬ್ರೆತ್ ಎಲ್ಲ ಕೊಡುತ್ತೆ. that is called as halitosis. ಬಾಯಿ ಬಿಟ್ರೆ ಕೆಟ್ಟ ಗಮನಾತ ಬರ್ತಾ ಇರುತ್ತಲ್ಲ ಆ ಥರ halitosis. that is called as halitosis because of accumulation of food in this diverticulum. ಆಯಿತಾ? ಸೊ ಸಿಂಪ್ಟಮ್ಸ್ ಇಸ್ dysphagia. there will be difficulty of swallowing because all the food is coming and accumulating here, and he will have to strive hard to swallow the food. And then there will be cervical web formation and halitosis irutte, and this food can come back into the mouth, and that is regurgitation. So most common symptom is dysphagia, and then halitosis, and then regurgitation. So complications ಏನಾಗುತ್ತೆ, if we don't treat this, what can happen is there can be a risk of aspiration. This whatever the food is getting accumulated in this diverticula can reach the lungs, and that is called as aspiration. Because of regurgitation, it can go to mouth or it can come back and reach trachea or lungs. And hence if it reaches lungs, if there is increased risk of aspiration, there is increased risk of infection of lungs, that is pneumonitis, and then it can get lung abscess also. Okay, if there is increased chances of lung abscess, there can be increased chances of squamous cell carcinoma of lungs. Okay, hence it can lead to lung cancer. Simple diverticulum can lead to complications like pneumonitis, lung abscess, and cancer of lungs. Hence it should be diagnosed and treated as early as possible. So what is the investigation of choice we'll do for Zenker's diverticulum? Barium swallow. We'll give patient the barium with fluid and we'll ask him to swallow, and when he is swallowing, we'll take an X-ray. That will show if there is any diverticulum or not. ಯೂಶಲಿ ವೈಟಾಗಿ ಅಪಿಯರ್ ಆಗುತ್ತೆ ಡೈವರ್ಟಿಕಲಮ್ ಇದ್ದರೆ. ಸೊ ಹಂಗೇನಾದ್ರೂ ಕಾಣಿಸ್ತು ಅಂದರೆ ವಿ ಕ್ಯಾನ್ ಗೋ ಫಾರ್ ಟ್ರೀಟ್ಮೆಂಟ್. ವಾಟ್ ಇಸ್ ಅ ಟ್ರೀಟ್ಮೆಂಟ್? ವಿಲ್ ಗೋ ಫಾರ್ ಕ್ರಿಕೋಫ್ಯಾರಿಂಜಿಯಲ್ ಮಯೋಟಮಿ ಆ್ಯಂಡ್ ಡೈವರ್ಟಿಕ್ಯುಲೋಪ್ಲೆಕ್ಸಿ. ಏನು ಮಾಡ್ತೀವಿ? ಕ್ರಿಕೋಫ್ಯಾರಿಂಜಿಯಲ್ ಮಯೋಟಮಿ. ಕ್ರಿಕೋಫ್ಯಾರಿಂಗ್ಸ್ ಮಸಲ್ ಇತ್ತಲ್ಲ, ಆ ಮಸಲಲ್ಲಿ ಒಂದು ಓಪನಿಂಗ್ ಮಾಡಿಬಿಟ್ಟು ವಿಲ್ ಪುಟ್ ಇಟ್ ಬ್ಯಾಕ್. ವಾಟ್ ಎವರ್ ದ ಡೈವರ್ಟಿಕಲಮ್ ಇಸ್ ದೇರ್, ವಿಲ್ ಪುಟ್ ಇಟ್ ಬ್ಯಾಕ್. ದಟ್ ಈಸ್ ಕ್ರಿಕೋಫ್ಯಾರಿಂಜಿಯಲ್ ಮಯೋಟಮಿ. ಆ್ಯಂಡ್ ದೆನ್ ವಾಟ್ ಎವರ್ ದ ಡೈವರ್ಟಿಕಲಮ್ ವಾಸ್ ದೇರ್, we'll suture it to the wall, to this muscle. So ಇಲ್ಲಿ ತೋರಿಸ್ತಿದ್ದಾರೆ, this is myotomy, cutting the muscle of cricopharynx and then suture it with wall of the gut. ಸೊ ಅವಾಗ ಏನಾಗುತ್ತೆ, ಡೈವರ್ಟಿಕ್ಯುಲಮ್ ಬೇಸಿಕಲಿ ಡೈವರ್ಟಿಕ್ಯುಲಮ್ ಹಿಂಗಿದ್ರು ಇಟ್ ವಿಲ್ ಬಿ ಇನ್ ಕಂಟಿನ್ಯೂಷನ್ ವಿತ್ ದಿಸ್ ಥಿಂಗ್ ಓನ್ಲಿ, ಏನು ಗಟ್ ಓನ್ಲಿ. ಸೊ ಅವಾಗ ಇಲ್ಲಿಂದ ಏನು ಅಕ್ಯುಮುಲೇಟ್ ಆಗಲ್ಲ, ದಟ್ ವಿಲ್ ಕಮ್ ಅಂಡ್ ಡ್ರೈನ್ ಇನ್ ಟು ದ ಸ್ಟಮಕ್ ಅಗೇನ್. Or ಇನ್ನೇನು ಆಲ್ಟರ್ನೇಟಿವ್ ಏನು ಮಾಡ್ಬೋದು, ವಾಟ್ ಎವರ್ ದ ಡೈವರ್ಟಿಕ್ಯುಲಮ್ ಇಸ್ ಫೌಂಡ್, ವಿ ಕ್ಯಾನ್ ರಿಮೂವ್ ದಟ್. ಇಫ್ ದೆರ್ ಇಸ್ ಲಾರ್ಜ್ ಡೈವರ್ಟಿಕ್ಯುಲಮ್, ವಿ ಕ್ಯಾನ್ ಜಸ್ಟ್ ರಿಮೂವ್ ಇಟ್, ಆ್ಯಂಡ್ ದಟ್ ಪ್ರೊಸೀಜರ್ ಇಸ್ ಕಾಲ್ಡ್ ಅಸ್ ಡೈವರ್ಟಿಕ್ಯುಲಾ ಎಕ್ಟಮಿ. ಓಕೆ, ಡೋಲ್ಮ್ಯಾನ್ಸ್ ಪ್ರೊಸೀಜರ್ ಅಂದರೆ ಏನು? ಇಟ್ ಈಸ್ ಬೇಸಿಕಲಿ ಡೈವರ್ಟಿಕ್ಯುಲೋ ಈಸೋಫೆಗಾಸ್ಟಮಿ. ಅಂದರೆ ಡೈವರ್ಟಿಕ್ಯುಲಮ್ನ ಈಸೋಫೆಗಸ್ ಜೊತೆಗೆ ಓಪನಿಂಗ್, ಬೇಸಿಕಲಿ ವಾಟ್ ಎವರ್ ಐ ಸೆಡ್ ಹಿಯರ್, ದಿಸ್ ಈಸ್ ಡೋಲ್ಮ್ಯಾನ್ಸ್ ಪ್ರೊಸೀಜರ್. ಮೇಲ್ಗಡೆ ಹೇಳಿದ್ದು ನಾನು ಕ್ರಿಕೋಫೆರಿಂಜಿಯಲ್ ಮಯೋಟಮಿ. ಐ ಜಸ್ಟ್ ಶೋಡ್ ಯು ಮಸಲ್ ಕಟ್ ಮಾಡಿ they'll suture it. Pexy ಅಂದರೆ ಬೇಸಿಕಲಿ ಸೂಚರಿಂಗ್ ಇಟ್ ವಿತ್ ದ ಕಂಟಿನ್ಯೂಯಿಂಗ್ ಈಸೋಫೆಗಸ್ ಅಷ್ಟೇ. ಓಕೆ, ಸೊ ದಿಸ್ ಈಸ್ ದ ಮ್ಯಾನೇಜ್ಮೆಂಟ್ ಆಫ್ ಝೆಂಕರ್ಸ್ ಡೈವರ್ಟಿಕ್ಯುಲಮ್. ಓಕೆ, ಕಂಟಿನ್ಯೂ ಮಾಡಲಾ ಅಥವಾ ವಿಲ್ ಗೋ ಫಾರ್ ನೆಕ್ಸ್ಟ್ ಕ್ಲಾಸ್? ಓಕೆ, ನೆಕ್ಸ್ಟ್ ಕ್ಲಾಸ್ ತಗೊಳ್ಳಾ? ಓಕೆ, ರೈಟ್. ಏನಾದ್ರು ಡೌಟ್ಸ್ ಇದೆಯಾ?
ನಾನು ನಿನ್ನೆ ಒಬ್ಬರೇ ಒಂದು ಡೌಟ್ ಕೇಳಿದ್ದೆ.